As with any procedure, as with anything that you do, there are always indications and contraindications, and that's true for RSI. Here's just a list of some of the indications, and I would expect everyone to review this full list. We think of indications of when a patient can't maintain their own airway, if they cannot protect their own airway, if they're not ventilating or oxygenating well. Imagine a patient that you've got on BiPAP that's getting extremely fatigued. Maybe they're starting to nod and fall asleep. That could be an indication. The anticipated clinical course. So this would be a rare situation, I believe, or a rare indication for us, but it is possible. The scenario where this would be the case for us is if a patient has obvious signs of airway inhalation injury or airway burns, and we anticipate deterioration, and we're going to be proactive in securing that airway. Now, the last one is to facilitate safety. There could be a time, although I would argue it's going to be exceedingly rare, where we need to intubate someone to safely transport them. Based on our experience in giving ketamine to agitated patients, it's very safe. It's exceedingly rare for us to need to intubate that person after giving a dissociative dose ketamine, and the majority of the time, those patients wake up in the hospital, they return to baseline, and they're frequently discharged from the ER. So just because someone is agitated does not mean that they also have to be intubated. However, we have had a few cases where we give ketamine. There are other things wrong with this patient, and the patient was not breathing adequately after the administration of ketamine, and they chose to intubate. This is a situation where you would move forward with RSI, or in this case, maybe we could call it DSI. So here's just a few examples. The classic pre-hospital example is a patient with a severe traumatic brain injury. They have signs of Cushing's triad. They are hypertensive, bradycardic. They have irregular respirations. Maybe if it's a patient that you expect them to deteriorate, we are ventilating with a BVM. Then generally, if we have to ventilate with a BVM, in most cases, an expertly performed RSI is probably better than ventilating them with a BVM on the way to the hospital. And then if a patient is altered, they're unconscious, and they have the potential for an airway compromise, or they're vomiting, they have a potential for aspiration, they have trismus, their jaw is clenched, they have an intact gag reflex. Historically, we would perform, or we would at least attempt, nasotracheal intubation, and we all know that is not always successful. It's most successful if we could go through the mouth, and now you will have that opportunity. Now, when we're talking about contraindications to RSI, we're not talking just about the patient where there's no indications. Here at Jessamine County EMS, our contraindications are going to be the inability to maintain an SpO2 greater than 92%. If we cannot get that SpO2 above that, then we have a shorter, safe apnea period. So that patient is most certainly going to desaturate during our efforts at securing that endotracheal tube. So our requirement is, even if you're performing delayed sequence intubation, if you've got an agitated patient and you've sedated them, you've induced them with ketamine, and then you are providing that procedural sedation to oxygenate them, to pre-oxygenate them, and you attempt to get that SpO2 above 92%. If you can't, then you do not proceed with a paralytic. You might proceed with, something else. You might proceed with an iGel. You might just continue to proceed with BVM ventilation. But you do not proceed with administering a paralytic because, we've given the ketamine and, the risk isn't that great if we maintain airway patency and we're ventilating with a BVM because that patient is hopefully still breathing spontaneously. But when we throw a paralytic in the mix, it can go downhill rapidly and that patient can desaturate, brady down, and go into cardiac arrest. Second contraindication would be an inability to properly correct or optimize the patient's hemodynamics. So if the systolic's less than 90 or if the shock index is greater than 0.9. So what is a shock index? How do we calculate that? It is the systolic divided by the heart rate. So imagine if a patient has a heart rate of 100 and a systolic of 100, would that patient be a candidate for proceeding with RSI? No. So what do we do in that situation? Well, we resuscitate the patient. We attempt to get the systolic above 90 or 100, and your indication for actually using a vasopressor or using push-dose epi would be to get the systolic above 100. That is our goal. Our goal is to get the systolic above 100. Once we optimize that patient, then we can proceed, but not until then. Because if we don't do these things, then the benefit of performing RSI absolutely does not outweigh the risk of that patient decompensating. There could be patients with a pelvic fracture or with intra-abdominal hemorrhage that we're not going to be able to adequately resuscitate. The patient would need a central line with massive transfusion to be able to safely intubate that patient. Now, some have said, well, I've seen the hospital do it. Well, that doesn't mean that it's necessarily the right or the safest thing to do, and it's not what we're going to do. Okay, third, severe acidosis without the inability to properly resuscitate the patient prior to intubation. So imagine a patient with severe diabetic ketoacidosis that has a pH of, below 7, and they're severely acidotic, and they are compensating by breathing 30, 40, 50 times a minute. They're blowing off that CO2. Well, ketamine can induce apnea. It's not guaranteed that they're going to keep breathing during the apneic period. And then it's not guaranteed that they're going to keep breathing after we give ketamine. And then we're actually inducing apnea. So the patient is going to be paralyzed and we're not going to be able to ventilate while we're trying to intubate. So that CO2 can rapidly climb, the pH can lower even further, and the patient can decompensate and go into cardiac arrest. Now, lastly, if the procedure is unlikely to be successful, so we looked at the physiologic criteria, there's also an anatomical assessment that you're going to need to perform on this patient before you attempt to intubate them. And we'll go over the anatomical criteria, but there's a lot of criteria listed here that isn't an absolute contraindication if you can improve and optimize your patient. Now, mnemonic to memorize, and you must memorize if you want to perform RSIs, the HOP mnemonic, HOP. Optimize hemodynamics, optimize oxygenation, and optimize the pH. So this slide is just to really make it stick when to not perform RSI or DSI or give a paralytic. This patient here, it would be difficult to optimize that patient. If they are hypoxic, it would be difficult to get a good seal on a BVM. It'd be very difficult to position them, and the airway's going to be more difficult to secure. So even if this patient is optimized hemodynamically, and their oxygen saturation is satisfactory, then they might still just be someone who's not a good candidate for pre-hospital RSI. So we really have to weigh the benefits and the risk. So the benefits are if we've got good airway anatomy, if we've got favorable physiologic parameters, if the patient needs it, and then we've covered the risk when there is a great risk. And you might be thinking, well, if the patient needs an airway, they need an airway. Well, that's not really true because, for the past however many years, we've managed the airway pretty adequately. We're trying to improve outcomes here, improve safety for the patient and for us, and reduce any adverse events. And we do that by selecting the appropriate patient, the appropriate time, and the appropriate procedure. And sometimes there are just certain procedures that are better performed with a team of 20 people around that patient in the OR with bronchoscopes and the ability to do a lot of different things that we cannot do. Now, a acronym that was coined, I think this was by Air Methods, but they have studied this and they came up with some criteria. They call it the HEAVEN criteria, HEAVEN being the acronym for patients that are high risk for this procedure. Of course, we've covered the hypoxemia, the extremes of size, so too big and too small, anatomically difficult. They have trauma to their airway, they have airway swelling, structural abnormalities with their airway, and then of course vomit, blood, fluid. And I'm going to say this and I'll say it again, that always lead with suction when you're intubating anytime, but especially when you're giving a paralytic and attempting to intubate. It's just not acceptable to miss an intubation attempt because you left the suction in the ambulance. Exsanguination, if you have severe anemia, hypovolemia, they can rapidly desaturate. And then, of course, if whatever is causing limited neck mobility or limited range of motion, if it's difficult to adequately position that patient. Now, if they're immobilized, there's emerging data that putting the patient in sniffing position, in proper ear-to-sternal notch position, does not increase the risk or the harm to a patient that has a potential spinal cord injury or unstable spinal column. And to go back to this, when we're performing RSI, if the patient has a cervical collar on it, then we pop it off. You can leave it on. You can hold manual inline stabilization if you choose and decide that you need to. And then after you secure the airway, you can put it back on. Now we're going to cover the specific steps and we're going to break it down, the steps of RSI. So there are 7 or 8 P's here, and I would expect you to memorize these. Now in the military, we also had 7 P's. It was prior proper planning prevents piss poor performance. So it's kind of the same thing, all right? The first P is preparation. Have plan A, plan B, plan C, and you need to verbalize that plan with your team. So the plan could be, well, are we going to do RSI? Is this a patient that we can optimize and then administer the induction and the paralytic nearly simultaneously, or is it someone that we need to sedate and then optimize? It could also be, I'm going in to intubate. If I am unsuccessful or the SpO2 drops below 92%, then I'm going to order a bailout. We'll reoxygenate and attempt again. Plan, B or C could be if the well, C is kind of a mandatory plan. If we cannot oxygenate, if we cannot ventilate, and the patient continues to desaturate, then I will proceed with a surgical crike. Second P is positioning, of course, ear to sternal notch with the head of the bed at least 30 degrees, 30 to 45 degrees. This applies to pre-oxygenation as well. Now, if a patient is having trouble breathing and they're on BiPAP, we're going to sit them upright as we're trying to optimize them. And then we can, once we have induced them and we've paralyzed, and we are going to then remove that and put a BVM on their face, plus or minus squeezing that BVM. We still don't want to bring the head of the bed back flat because patients desaturate faster when they are flat. So you have a longer and safer apneic period if the head of the bed is not flat. Pre-oxygenation. You all know the rule of 15s. We have covered this incessantly over the past few years. So what are the rule of 15s? 15 PEEP, 15 BVM, 15 nasal cannula. Now, the 15 nasal cannula can stay on for the duration of the procedure because we can continue administering passive oxygenation during our efforts at securing the tube. The pre-oxygenation period has to occur for 3 minutes. So while I am pre-oxygenating that patient, once that SpO2 gets above 92%, we have to track the time. I don't care how you track the time. If you mark the time on the ventilator, if it is 15:30 and you say, okay, we have to pre-oxygenate, we've reached our goal of 92%, mark the time 15:30 or 33, and then you say, all right, we need to pre-oxygenate to 15:36, or you can use a stopwatch. You can use hand heavy, you can use your phone, you can use your watch, but you've got to have a timer, and whoever is timing that needs to let everyone know when they are at that 3-minute period for adequate pre-oxygenation and denitrogenation. Now, what happens if the SpO2 falls below 92%? Well, you bring it back up and you start the 3-minute period over. Prepare your equipment, your suction. Have the suction on, running. Have the yank hour under the head of the bed. Test it. Make sure all of the pieces on the top are closed so that you get an actual vacuum. And you're going to know this if you test it properly. If you kink it and you look to see the vacuum or the suction pressure go up. Pressors. Anytime we're performing RSI, we want to have put at least, at a minimum, push dose epi ready on hand, ready to go, labeled, pre-mixed. Then the next P stands for paralysis induction. Induction comes first. Then pressure on the thyroid. I want my partner, my RSI assistant, having their hand on the thyroid, ready to perform external laryngeal manipulation. And then we proceed with placement and proof. So placement of the endotracheal tube and waveform capnography is the gold standard. And then comes post-intubation management. So here's a sample timeline. Here's kind of how that looks if you compare RSI and DSI head to head. The only difference is in DSI, you'll see that the patient is not tolerating your pre-oxygenation effort. So we give ketamine before, and then we pre-oxygenate, and then we administer the paralytic. Remember, the duration of action of ketamine is long enough for us to be able to give ketamine, get that patient under control so that we can resuscitate them, and then resuscitate them for the 3 minutes, getting that SpO2 above 92%, and then administering paralytic. After that, it's kind of the same thing. Now, after the paralytic, we're going to wait around 60 to 90 seconds. It's better to wait a little bit longer to ensure that that patient is fully paralyzed. But if you're given succinylcholine, the positive thing about it is that you have the fasciculations. Earlier, I talked about comparing succinylcholine and rocuronium head to head. And a lot of people think that the benefit in succinylcholine is because you kind of know when it starts to work And then after the fasciculations, you check the masseter tone. If there's relaxation, then you proceed with intubation. And then it's confirmation and post-intubation management. Now, something we don't talk about a lot, we talk about the sequence, but what happens if it goes wrong? What happens if I'm attempting to intubate and the SpO2 starts to drop? Well, then you back out. You call a bailout or an abort. And this is a mandatory abort. It's not an optional abort, but you pull out. You re-oxygenate like they did in that study that we talked about at the beginning. You re-oxygenate, bring the SpO2 back up, and then you proceed with intubation. Well, what happens if that one fails? The second intubation attempt fails, or we can't intubate, or the SpO2 drops again. Then you do that again, except instead of proceeding then again with intubation, you place a supraglottic device. Instead of rapid sequence intubation, it is therefore then, call it whatever you want, rapid sequence airway. You place a supraglottic. So again, here's the full sequence, not just the drug sequence. Both. So you start off applying oxygen as soon as possible. You're taught to just get the SpO2 above 93, 94% if they're having a stroke or a STEMI. That is not true in the patient that you're thinking that you need to intubate. You start off positioning, and as soon as possible, you apply the most aggressive means of oxygen that the patient will tolerate. So again, the debate for when to perform delayed sequence intubation versus rapid sequence intubation is fairly straightforward, but it is important that in both you want to ensure proper optimization and resuscitation so that the patient does not decompensate. Whatever you choose to do, RSI versus DSI, that is the key, is patient optimization. And the argument is that, well, in both, ultimately if I'm thinking I can do RSI and I'm starting off with a non-rebreather and I find out that I can ventilate with a BVM, historically with RSI, the point was not to use a BVM, but I think there's a paradigm that's shifting showing that a BVM, careful, perfect, not overzealous BVM ventilations can be safe even with RSI. So the roles are provided amongst crew 1, crew 2. So ideally, crew 2, think of the person that is in charge of overall monitoring. That's likely going to be a supervisor or somebody that is RSI credentialed, somebody that has been checked off by the medical director as being able to organize, oversee, and perform this procedure. Although technically the roles can switch, it doesn't. We're not going to predefine a supervisor as having this particular role, or a person who is RSI credentialed. But the RSI credentialed person, if there is only one, will ultimately be in charge of the safety aspects and the overall resuscitation and the overall procedure. But either way, you need to you need to split up the roles during the procedure. You need one person responsible for airway management. That person is going to set up all of the equipment. That person is going to ensure BVM ventilation is going, that you have end-tidal, that you have a nasal cannula underneath. They're going to be evaluating the airway. They're going to ensure denitrogenation, and overall, they're going to be intubating, which is, we think of this as RSI equaling intubation. That's true. We perform RSI for intubation, but that's probably not the crux of the whole procedure. That definitely is not the crux of the whole procedure. Crew 2 is likely the most important person. Think of it as a cardiac arrest. The most important person is the one that's doing the fundamentals very well. And in RSI, yes, good BVM ventilation and good optimization is the fundamentals. But in RSI, you really have to have someone that is organizing, that is assigning roles, that is coming up with a plan A, B, and C, and the one that's making sure the important stuff that needs to get done is happening. So in my opinion, that is crew 2. That is the person that is ensuring that the monitoring equipment and the access is obtained before we get too excited about intubating this patient. All right. Think of IV or IO access and the monitoring equipment as what tethers that patient to this ground. It keeps them from fluttering and flying off into the sky. So that is what must be in place before we begin. And you can imagine and envision these two responsibilities occurring simultaneously. So crew 2 is also going to get fluids running wide open unless there's a contraindication, but don't forget the pressure bag. Have a pressure bag on. That will be on the checklist, the mandatory checklist that must be used with every procedure. Crew 2's going to be so if crew 1 is ventilating, if their hands are on the BVM, crew 2's going to help make sure that all of the equipment's ready. They're going to be drawing up the sedative and the paralytic. They're going to be putting labels on it, and they're going to be doing a mag check. They're going to assist in confirming the emergency plan. They're going to talk it over with crew 1. If this airway is a failed airway, here's what we're going to do. If we don't get this tube, here's what we're going to do. Don't move forward without a plan. And then after intubation, during intubation, both eyes on the monitor, all right? Both sets, 2 sets of eyes, 4 total eyes. It's better than 2. But you also need someone staring at that monitor because you don't want to get absorbed in that intubation, not seeing that that patient is rapidly decompensating, that the SATs are dropping, that the heart rate's dropping, and that patient's about to arrest. Now, this is the checklist for crew 1. And we've talked about this already, but there's an acronym. Learn this acronym. Pause the video now and go over it. The setup. We know the setup. The mask control. 2 thumbs down. Hand pulling the mandible into the mask. Positioning that patient ear to sternal notch. Making sure there's end-tidal with every single breath. They're evaluating for a tension pneumothorax. They're seeing if the patient is difficult to BVM ventilate. They're evaluating for gastric distension. Then it's optimize ventilation. So people ask, well, if we are using a BVM, do we need to ventilate? Do we need to squeeze the BVM? The answer is it depends. If you have a patient, so in either scenario, if you're performing DSI and you administer ketamine to sedate that patient, or if you're doing RSI and you want to deliver the maximum oxygen therapy that you can, so you want to start with the BVM and a nasal cannula underneath. The question then becomes, do we need to squeeze the BVM? The answer is yes and no, as Chris Wilhite would say. If that patient is breathing spontaneously with adequate tidal volume and you have a PEEP valve on and a nasal cannula underneath, then you don't have to squeeze the BVM. However, if their ventilations are not adequate, or they're not breathing spontaneously, or they're not oxygenating or ventilating well enough on their own, or they have severe metabolic acidosis, and you sedate them, and you want to ensure their rate that they're compensating with does not drop, then you gently and carefully squeeze the BVM, not aggressively, not too fast. You want to make sure the rate's not too high. You can, with careful, Tom Boothway calls it princess ventilations, where you kind of just squeeze a little bit of the bag, monitoring end tidal to make sure that you have waveform capnography. So yes and no. You're going to have to decide if you need to squeeze the BVM or if you don't. Now, if we don't have the rule of 15s in place, if we don't have that nasal cannula on underneath, then that patient is not getting oxygen in between those breaths because there's a one-way valve on that BVM. So breaths only come in when the BVM's being squeezed. Now, there's 3 O's in this smooth, 3 O's in this smooth, all right? So optimize ventilation, observe for difficult airway. You're going to check Mallampati, see if the neck's mobile, 3-3-2. So, 3 of the patient's fingers in their mouth, see if it'll fit. 3 here, and then 2 here, and I've got a picture of that. So think about it this way. If the patient has limited mouth opening, if the distance from the base of the neck to the tip of the chin is short, or if they have a short distance from the top of their thyroid to the basically their chin, their jawline, or the flat part under their chin, if anything's less than that, that's an expected anatomically difficult patient, and you should prepare accordingly. And then you identify your plan, you communicate those plans with your assistants, and then oxygenate. So you've got to have someone be a timekeeper. You've got to have at least 3, no less than 3, but preferably 5 full minutes of denitrogenation. So actually, the majority of the molecules that take up the most space in the lungs is nitrogen. So by pre-oxygenating, by delivering 100% oxygen to the lungs for that time period, you replace the nitrogen, the space that the nitrogen takes up, with oxygen. And that gives you a safer apnea time. And then tube delivery, always suction leads the blade. As you're going down, call out what you're seeing. I see uvula, epiglottis, arytenoids, which is like the posterior notch, and then the glottis. And hold that. So as you pass the tube, you hold it. You don't do anything. You stick it in, you keep your screen in, and you keep your tube in, and you hold it, and you have someone pull out the tube or the bougie, or not the tube, have someone pull out the rigid stylet, the other stylet, or the bougie, and then you inflate cuff and you confirm. Crew 2 is monitoring and medications. All right, monitoring and medication. So everything's connected, keeping that patient from floating away. And these are your matters steps. MATTERS. Monitor, access, and perfusion. They're improving that shock index. If it's high, they want to bring it down. If the systolic is less than 90, they're trying to get that above 100. They're connecting your suction equipment. They're testing it. They're getting all of the equipment laid out and ready to go. That suction's placed under the head of the stretcher. You've got one endotracheal tube and a size smaller. Remember, it's easier to pass a tube if the tube is a smaller size. Okay, and then the videolaryngoscopy is on, being warmed up. We've got the size 3 hyperangulated blade, or size 4 if it's a larger patient. We've got the bougie out, ready. We have our supraglottic device ready to go in case it's a difficult airway. We can't place the tube or the patient rapidly desaturates. And then the tube holder is behind the neck in position, ready to go. And then the therapeutic prep refers to the aforementioned RSI medications. Now, if there's a succinylcholine shortage, then we'd switch this to rocuronium. But again, it's ketamine, 2 milligrams per kilogram. You would half that, 1 per kg, if they're elderly or if they're hypotensive. And always perform a MAC. And then comes your emergency plan comms. And then you administer the medications. So the exact timing of the medications depends on if you're performing RSI or DSI. And then it's safety monitor, end tidal. After you place the tube, it's also tape for axillary lung sounds bilaterally, no epigastric, and mark the ET tube depth. Again, we're looking roughly, the rule of thumb is 3 times the size of ET tube. So if they're intubated with a 7.0 tube, you would expect roughly 21 at the lips, and we will mark these at the lips and document it. So these are side by side, and you can see how this works in conjunction, okay? So it is crew 1 does this as crew 2 does this. Crew 1 does this as crew 2 does this. And for anyone interested in the credentialing process, these steps will be required to be able to be switched and memorized. Airway management. Now, we've covered intubation and just general airway management a lot, but we are going to recap this. Our goal is definitive airway without, that's what I believe SANS means. It only makes sense that SANS means without. So definitive airway sans hypoxia on the first attempt. Our goal is not to intubate this patient. Well, that's why we're paralyzing them, Floyd. Of course, our goal is to secure the trachea with an endotracheal tube. Yeah, but ultimately, if we don't get the tube, then what? What harm befalls that patient if they're pre-oxygenated, if we abort the attempt before they decompensate, before they desaturate, and then we effectively ventilate them back up and oxygenate them back up and give a pressor if needed? What harm befalls that patient? Well, there's maybe some, but not nearly as much harm as if our only goal is to intubate. So ventilation and oxygenation is preferred over intubation. We must aggressively tackle the pre-ox and but resuscitation continues through the duration of the procedure. We must aggressively attack this as if someone took your dog and your John Wick. Is that what happened in John Wick? Can't remember. So those are our goals. Now, something you should already be aware of, squeezing the BVM harder and faster is not the way to increase the SpO2. 2 things improve oxygenation. That is increasing the PEEP and increasing the percentage of oxygen that you are delivering. So if the SATs are low, the initial step is not to squeeze harder or faster. It is to increase the PEEP and how much oxygen we are delivering. Now, how do we position the patient? We don't want them flat, okay? We want ear to sternal notch with the head of the bed about 30 degrees. This is easily accomplished with a stretcher.
Hey guys, welcome back to Core EM. I'm Anand Swaminathan. This is core content for anyone, anywhere, and just in time. I'm here with one of our PGY4 residents, Ben Cleary.
Hello.
And behind the camera, as always, is Salil Bandari, one of our other faculty members. He's not going to wave to you guys, though. And we're going to do a really quick video looking at the bed-up, head-elevated position for intubation. Now, this is something that Ben reviewed a couple weeks back for us on our EM Journal Update series in our conference, a paper that was in the anesthesia literature looking at this position for intubation and how it improved our ability to intubate. So, Ben, why would we actually do this position? We've been intubating people flat for a long time, and I'll be honest with you, my success rate's pretty good. So why change? Why do this bed-up, head-elevated position?
Yeah, well, the anesthesia literature has shown for years that patients get better pre-oxygenation and longer safe apnea times in the bed-up, head-elevated position when compared to the supine position. Rich Levitan has been talking about this for years. Patients oxygenate better and stay oxygenated longer when standing or sitting compared to lying down, because less of the alveoli are dependent. Makes sense. Patients are more comfortable if they're hypoxic when they're sitting up than lying flat. Add to this that with our obese patients, you get that massive tissue off of the chest or abdomen And finally, some anesthesia literature also shows that you get improved glottic views with direct laryngoscopy in this position compared to supine.
All right, so if we intubate with the patient up, the first thing is the alveoli, less dependent alveoli, so better pre-oxygenation, longer safe apnea time, so we're going to keep those oxygen saturations up higher for longer. We may get a better look at the glottis according to the anesthesia literature once again, and in our obese patients, we're going to offload some of that mass. So, all right, so let's go ahead and let's demonstrate the actual position. So I'm going to go ahead and hop up on this bed here.
Right, so the patient's going to be in the supine position. The first thing to do is align their head with the head of the bed. So oftentimes you'll have to actually bring the bed into Trendelenburg, and then either the patient will move them up or you can pull up. Once they're in Trendelenburg, you leave them in this position, but then rise the head of the bed to at least 30 degrees. Finally, if you need to, you can get that ear to sternal notch by putting a blanket or towel or something like that right behind the shoulders to really get that alignment you want.
And we could use our CPR pillow.
Takes 15 to 20 seconds. Recommend doing this position during pre-oxygenation and continuing during intubation to prolong that safe act.
And I will say that, most of the time we're going to want to perform RSI in the truck, if at all possible. Our goal should be, if we think we need it, let's try to do it in the ambulance, at least when we're starting, until we get some under our belt. So the pre-ox, how do we pre-oxygenate them? What kind of oxygen delivery device do we choose? Well, the answer is as much as the patient will tolerate. In all cases, we should put an end tidal at 15 under all of these, or not an end tidal, sorry, a regular nasal cannula. End tidal, not to be used for pre-oxygenation. So, might there be times when a non-rebreather and a nasal cannula at 15 is adequate? There could be. If that patient tolerates higher, would we want to deliver more O2? Probably. It's probably safer to deliver higher O2. But again, going back to the traditional ways of performing RSI, the whole purpose of it is a patient is tolerating your pre-oxygenation efforts. They're breathing adequately and spontaneously. You're able to get their SpO2s up easily. And if you can get their SpO2 to 100% with a nasal cannula non-rebreather, then it's probably sufficient. If a patient will tolerate a BiPAP, then that is a great way to pre-oxygenate your patient if they are compliant with the mask, but they're getting fatigued. And then there might be cases where a patient's not breathing adequately and we need to ventilate them with a BVM, or maybe they're breathing adequately, but they're not tolerating our ventilation and oxygenation efforts. So we're going to give them ketamine, perform delayed sequence intubation, lay them back about 30 or 45 degrees in the position we just watched, and ventilate them with a BVM. So this is why and how the nasal cannula works for passive oxygenation.
Using a BVM here with an aggressive jaw thrust and an oral airway, 25 liters via BVM. Not much happening in the lung. It's collapsed and it really remains so. There are nasal prongs on, but there's no oxygen being administered at this point. And here, what we're using is 25 liters both through the BVM, but also through nasal prongs with a jaw thrust, but no PEEP. If you look very closely, there's the occasional alveoli that you can see it's being recruited, but not much happening. So what we're going to do is add a PEEP valve and dial it up to 10. And so 25 liters via the BVM passively, 25 liters via nasal prongs, aggressive jaw thrust, and 10 of PEEP. Let's take a look and see what's happening. Pretty impressive, progressively more alveoli being recruited.
Now that would not happen without a PEEP valve.
Completely expanded just by passively applying high flow oxygen through the BVM and nasal prongs with a good jaw thrust.
So that shows if a patient is ventilating effectively and you place a nasal cannula on underneath at 15 or higher, and then you have the PEEP valve on the patient, then you are essentially providing CPAP, all right? So you're still providing continuous positive airway pressure, even if you're not squeezing the BVM. And in between breaths, you're still delivering that. So that's why we do the rule of 15.
And 10 of PEEP. When you let go, it deflates, and apply it, it completely re-expands the lung. So again, let's just take a look. Expands and collapses. Now
and watch how little of a breath it takes to re-expand it lung
actively. So just one partial breath re-expands that lung. Now I'm going to let go. Lung's going to deflate using.
So if you have a perfect seal and that lung remains inflated, the alveoli remains recruited, it takes very little to re-inflate that lung. But the seal must be perfect or you're going to lose all of the recruitment that you have obtained. So we've covered this. If you need a review, you can pause and look at that. So how long do we pre-oxygenate? At least 3 minutes, preferably up to 5. So why does the oxyhemoglobin desaturation curve matter here? Because isn't it about if they're acidotic, it shifts here. If they're alkalotic, it shifts here. That's right, but you see this slope at the top. There's a flat period, all right? After this flat period, there's a rate at which it drops precipitously. Now, when a patient is adequately pre-oxygenated, there's a very long time before they start to become hypoxic. So if you maximize their SpO2, you get it as high as possible, and you do that the minimum of 3 minutes of pre-oxygenation, when you stop pre-oxygenating them and while you're attempting to intubate, you won't have to rush. You're going to have a longer period before the patient starts to desaturate. But right around that 93, 92, 91 part, that is when they start to desaturate rapidly and precipitously. And then it's hard to pre-oxygenate them from that point. So this is kind of how we want to position the patient here. Now, I will admit that we should probably be moving our fingers closer down to the angle of the mandible so that we can pull that jaw forward, which is pretty easy to do if the patient's unconscious. And then we can really position that patient perfectly. And for our BVMs, of course, we'll have the elbow, and then we'll have the filter needs to go between the end-tidal and the mask, because if the patient has any stomach contents coming up, then it's not going to compromise your filter, or it's less likely to compromise your end-tidal. This is what it looks like when you do a jaw thrust. That is why a jaw thrust is so important. And then this is an MRI image of what happens when the neck's like this versus like this. So positioning and then jaw thrust will really open up your airway anatomy and make the oxygen that you're delivering more effective. Watch that again. Okay. So there are different ways to hold the mask. Ideal is 2 hands on the mask, one person squeezing the BVM or putting the BVM between their chicken wing. There is another method where you really, if you see the image on the bottom right, if you really put your hand more center and you put where the BVM connects to the mask, if you put that right in the indention here, well, I'm trying to get that in picture, right here, then it will evenly distribute the pressure that you're applying to the mask, so you're not putting too much pressure on one side or the other, and it will enable a better seal. And then you just use your other fingers, reach around to the jaw and pull it back. So the time at which the number of minutes that you have until that patient desaturate is also related to how sick that patient is. So a normal adult that is adequately pre-oxygenated, it could take them 10 minutes before they desaturate to SaO2 of 60%. However, a moderately ill patient desaturates faster. But who desaturates the fastest? Obese adults and children. They desaturate faster. So when we're talking about our HOP killers and our Heaven Airway criteria, obese adults and children, we're not going to RSI children. Now, I'm not saying you can't RSI obese adults. I'm just saying you really have to weigh the pros and cons, the risk versus the benefit of doing so. Now, if you're trying to ventilate or oxygenate a patient and you're only able to get the SpO2 up, let's say you throw a non-rebreather on at 15, 25 liters a minute, and the SpO2 is still not coming up, it's only coming up to in the 70s, that patient, by definition, has to have some type of shunt physiology, which is where you have alveoli that are getting oxygen is getting to some of the alveoli, but not the others. So you have oxygen flowing through the pulmonary arteries, and it is not picking up oxygen and offloading CO2. So you have a mixing of oxygenated blood from the alveoli that are ventilated and deoxygenated blood from the pulmonary artery that was not able to get oxygenated. So if you have a shunt, you must provide positive end expiratory pressure by means of CPAP, BiPAP, or BVM with a PEEP valve. So imagine this scenario. You have a 78-year-old male. You got called for difficulty breathing. During response, during your response, dispatch advised that the patient was no longer responding. You find the patient slumped over in the recliner, barely responsive, breathing agonally. You throw this patient on a 15-liter non-rebreather. The SpO2 is 84%. They're tachycardic. How would you manage this patient? Well, this patient is likely a candidate for RSI, but not with the current SpO2, and we're going to have to obviously sit them up as we would any other patient, or at least raise the head of the bed at least 30 to 45 degrees. The higher that you can, the better. We're going to have to use a BVM with a PEEP valve. Non-rebreather at least 15 to get their SpO2 up. So here was a case of bag valve mask ventilation during tracheal intubation. And what they did was, with the intervention group, they used a BVM between induction, all right, so when they administered the sedative, and the first intubation attempt. They provided education. They used a PEEP valve, OPA, two-handed grip, and a ventilation rate of 10 per minute with only enough tidal volume to make the chest rise and fall. In the comparison group, they did not use a BVM. They did not allow it between induction and the first attempt like they did in the intervention group, unless the SpO2 was low or the physician thought it was required. And you can see the comparison of the patients that desaturated who did not get ventilation versus those who did. Now, with this information and the science that we shared with a similar study at the beginning of this lecture, it's pretty evident to me that if you provide careful, deliberate ventilations, even if the patient's apneic or between the induction period and the intubation period, that it is safe if you do it very carefully.